Hi, good morning. My name is Vicki Lowe, and I'm the Executive Director for the American Indian Health Commission, and welcome you to our panel discussion on tribal partnerships with ACHs. As I said, I'm the Executive Director of the American Indian Health Commission. I am also Jamestown S'Klallam and Bella Coola First Nations, and have been working in the Indian healthcare delivery system since 1996. I have with me some great partners that we work with on a regular basis to share their experiences and working with the ACHs since the implementation. And I'll just give them a minute each to introduce themselves. It looks like Andrew's ready. Andrew, do you want to unmute yourself and introduce yourself?
Good morning, Vicki. Can you hear me?
Yes.
Great. Good morning, everyone. My name is Andrew Shugren. I serve as the Health Policy Director for the Digwalich Wellness Center, which is run by the Swinomish Indian Tribal Community up here near Anacortes. And I have participated in this effort to work with the ACHs and create tribal partnerships, both here in the North Sound and in the Olympic communities of health. And I look forward to this presentation.
Thank you, Andrew. Tony, are you able to turn on your video?
No, it said the host has stopped it. So is that?
Uh-oh. You're already in trouble, Tony.
I know, right? Oh, wait. This says I can start my video now.
Oh, there you are.
There. Let me in. Hi, I'm Tony Lodge, and I'm the CEO of the Native Project in Spokane. The Native Project is a Title V Urban Indian Health Clinic and FQHC HRSA 330 clinic. I'm a citizen of the Turtle Mountain Chippewa tribe of North Dakota, but I've lived in the city for 40 years. So that makes me a pretty established urban Indian. So we shall have more conversation as we go along. Thanks for inviting me.
Thank you. And then we also have with us Catherine Saluskin from the Yakima Nation Behavioral Health. Catherine, do you not have video? And Catherine, if you're talking, you're still.
Can you hear me?
Yes. Hi.
Hello?
Good morning. Thank you for joining us.
Good morning. Shikmaisky, Inknashmanikshas, the Inuit, Pashtawaki, Catherine Saluskin, and I'm an enrolled member of the Confederated Tribes and Bands of the Yakima Nation. I am the Program Director for Yakima Nation Behavioral Health Services. I've been the Program Director for about 8 years. And when we started our program, I was one of 7. Now our organization has grown to almost 50 people under our umbrella. We have a clinical special projects unit and a victim resource program under the behavioral health umbrella. And thank you for inviting me.
Thank you, Catherine. So when the Washington State was developing the waiver for Medicaid transformation as required under the state and federal consultation and confer policies, they came to and it was Jenny Hamilton back then, brought the tribes together for a meeting to talk to us about this, Medicaid transformation. We can do all these great things. And we were like, how much money is it and what are the rules? And Jenny kept saying, oh no, it's really innovative, be creative. And we're like, how much money is it and what are the rules? And so from the very beginning, just wrapping our brains around the concept of this Medicaid transformation has been difficult because the tribal and urban programs live in this very underfunded world. We get 32 cents for every dollar needed to provide care to our people. So in some ways, we're kind of maxed out on innovation. So to try and be more innovative that we're already being was a little, mind-blowing, I guess. So as we kind of worked through and the state continued to develop the accountable communities of health, there was some issues with governing boards and how that works, again, because of that consultation policy, and it kind of not really carrying down through the local entities because they're non-governmental. And then the commission became the tribal coordinating entity for the tribes in the urbans of Washington State. And our relationship with them is already that we work for them. So it's a little bit different than the ACH relationship. So it's like an ACH lookalike. But it was our job to help the tribes in the urban programs engage with the ACHs in their region, which was no easy task, let me tell you. The tribes in the urban programs very busy, adding one more meeting. I was a little bit afraid to approach some of the tribal leaders and staff about the thought of one more meeting. And really, there was a lot of thoughts about what is this going to be? Is it going to go away in a couple years? What is the benefit to us? So, so I think the main thing was that there was money. And that was really important. And I think that's how we got the tribes and the urbans to the table, let's be honest. But we had to have it happen in our own way. So I'm hoping that Andrew, Tony, and Catherine can tell us the story of how that happened in their region. So I'm going to start with Tony because she's my elder and our role model here. Also because they had the most difficult region for this. So Tony, you want to tell us a little bit how things were in your region when we first came over there and tried to have the engagement with the ACH? It was a very interesting story.
Well, yes, I will tell that story. And just to quote my young friend, Vicki Lowe here, it's the only public meeting she's ever been to where people ended up crying. That's how bad it was. And so we just have to be really honest here. If we're having a conversation about equity, that's been the blessing and the gift of George Floyd and all of the fallout, is that we really are at the table now to have a honest conversation. And I don't want to start out in a negative way. I'm going to start out in a truthful way. Yes, our relationship with our ACH was probably one of the most painfully institutional and structural and personal experiences in racism that I've ever experienced in my life. And it's for so many reasons, and we've worked through it. I just have to say, I think I was probably at the first meeting. The Affordable Care Act was passed on March 23rd, 2010. I remember it because it was my birthday, and I sat at my desk and cried. I knew it would have that much impact in our community and bring so many resources to our community. And it was a great birthday present. But right after that is when we started getting organized, went to every meeting. And for us, Indian Health Services is an integrated system of care. It is behavioral health and medical together. In my clinic, I'm licensed substance use, licensed mental health, and I offer medical dental pharmacy, as does every Indian Health Service clinic almost in this country, offers that integrated model that I thought all these guys were trying to get to. But anyway, and I have a lot to say, and I know my colleagues here are, I love listening to them too. But I just want to say, part of the start of the integration that did not work was, I think, people's own limited public school education. And that's not an indictment, but it's true. You know, I is for Indian, Indian is for a reservation, Indian is for tribes, not looking at the Affordable Care Act, which actually for the first time ever elevated Indian Health Services to an ITU system of care, tribal, Indian health and urban. And we are partners in the system of care to serve Native citizens. So that's what's hard for people to understand. I'm a citizen of a tribe in North Dakota. Because I live in Washington State does not mean my rights as an Indian citizen go away. And in this country and in this state, 70% of all Native people don't live on a reservation anymore. So when the ACH, when Better Health Together went to form partnerships, they only went to the tribes. And we sat in that meeting that day, and all 4 tribes in this region said, we want Tony Lodge to be our representative on the Better Health Together board. They wanted me, because I'm old, as Vicki said, as she pointed out once again. But I've been doing this a long time. You know, I took $100 bill, we, and made a $10 million clinic out of that $100 bill. We know how to make this work, this partnership, this entrepreneurial meeting. And Better Health Together said, absolutely not. You will not be our representative on the board. And so that's how it all started. So I'll turn it back to you. Go, Vicki, you're back.
Thank you, Tony. Yeah, it was the only meeting, professional meeting I've been to where people actually cried, and it was one of the hardest meetings I've ever been in. But thank you, Tony, for your leadership. Andrew, you had a unique experience with the ACHs. You started out over here on the Olympic Peninsula with the OCH, and now you're up in North Sound. Do you want to talk a little bit about how the beginnings of the OCH? I think they went through several changes in leadership, and how they viewed the tribes. Is there 7 tribes over in here? I should know that. Yes. Thank you.
Thanks, Vicki. As I mentioned, my name is Andrew Sugarin, and I want to share a story before I get started. My young friend Tony Lodge reminded me of this, and my even younger friend Vicki has been part of this journey that I've been on. When I started as the health director for the Quileute tribe, which is out on the Washington coast, I went to a meeting, and my executive director sent me and said, if Marilyn Scott taps you on the shoulder, you do whatever Marilyn wants you to do. And sure enough, Marilyn tapped me on the shoulder at this meeting and asked me to start serving on a foundational public health services committee with the state, which I probably would have said no to because I was relatively new, but Marilyn asked me to, so I did. And so that was that was the first step on a journey that has led to the state elevating tribes to be part of the public health system in Washington state, which hadn't been recognized. But it was a long journey. It was a lot of work. There was a lot of education that had to happen on both sides for that to happen. And it was through that process that we created a much stronger partnership between the state and the tribes. And so when Liz Baxter tapped me on the shoulder a few weeks ago and said, can you serve on this panel? I had this idea in my head that it was going to be a panel presentation. Maybe there'd be 20 or 30 people. And I looked down and there's 320 participants, so I'm a little bit nervous. And I really appreciate Liz tapping me on the shoulder. And I appreciate my young friend, Tony Lodge, reminding me of that story, and the journey is in where you end up. So when the Olympic communities of health were starting to be formed, and as Vicki touched on, there were several leaders, but one of the initial leaders really didn't want tribes to participate. And I looked at the language just like Tony did and realized that tribes needed to be a participant in this process and needed to be at the table because an elder has shared with me this saying that I carry around and has been widely shared, and that is, if you're not at the table, you're going to be on the menu. And that was my concern, that we were going to be on the menu. And we were on the menu initially. I asked to be part of the planning process and that I be invited to meetings. And I didn't hear anything. Next time I ran into that leader, I said, hey, look, I want to be invited to all of the meetings. You're getting paid to put this process, this Olympic communities of health together, and tribes need to be a part of it. There's 7 tribes in the region. We need to be at the table. We need to be part of the planning process. And I didn't hear anything back again until there was a kind of a general convening for everybody in the region. And obviously there had been a lot of planning that had gone into that. And we had not, as tribes, been able to participate in it simply because we weren't told when the meetings were. I was fortunate to get an invite to a steering committee meeting where they were making major decisions. And I was able to do education in that room of the people that were there who just did not have an understanding of what tribes were, how they integrated into the public health system within the region, and they recognized that it was important to have tribes at the table going forward. And so we were able to affect that change and to become part of the decisions of the OCH moving forward. We were super fortunate to be part of the planning and the hiring for the first executive director for the Olympics Community of Health. Elia Moore Prisitkowski was our first executive director, and she got tribes. She had been working up in the Bellingham area. She'd been working with tribes up there. She understood the work that we had been doing and why we had to be super creative with the limited amount of monies, and that the region had something to learn from tribes. And so that started a process at the Olympic Communities of Health where tribes have a seat at the table. We're on the governing board. We've had tribal leaders be on the executive committee and serve as secretary. And it's been really important work, not only for tribes, but for the region, so that that the region could understand why tribes needed to be at the table and how they could benefit from having tribes at the table. And so that was really exciting work. It's been really gratifying to see the growth and the understanding of how tribes fit into healthcare and what we're providing to not only our own communities, but the community as a whole. And we have 7 tribes. We have 7 unique ways of providing services. But almost all of the tribes provide and care about the greater community. And so when I had, so I've worked, so that was kind of the genesis and the growth at Olympic Communities of Health. And I remember at one point there was a funding that was going out, and we took a look at it and we said, and the metric was that you were showing improvement in that metric in order to keep getting the money. And we realized we were already doing all that work. So we ended up not applying for it because we weren't going to be able to show improvement in that metric because we were already integrated when we were provided that care.
Right.
So I had the opportunity. I'm working now at Digwalich, and we have, there were some similar challenges in the North Sound, but we have a really super good relationship now. We're on the governing board. We sit on and we participate we participate fully with the North Sound. And I know I do want to say thank you to Liz Baxter, who stepped up. One of the things we realized as we were moving forward, maybe not everyone's familiar with Digwalich Wellness Center and the model that we provide, but we provide a we provide a number of services at our wellness center. And it's a wraparound service, but we forgot one. We forgot dental. And so we're right now in the process of adding dental to our facility, and Liz and the North Sound stepped up to help provide funding for our dental equipment. So I just want to say thank you. And Vicki, I think I'm going to stop there because I know we have one more speaker and limited time. Thanks.
Yes, thank you, Andrew. You did remind me of one point I really thought it was important to make, is that I think the ACHs in the state in the beginning didn't really understand tribes and the urban programs and how they fit into their idea of sectors, because we cover more than one sector. So when you're bringing a tribal and an urban leader onto your board, you're actually covering, it's not the Indian sector, it's not the tribal sector, it's, as health, behavioral health, dental, working with school age kids, some tribes have everything except for a hospital. So there was a lot of really having to understand and think about how the system was once again created that really didn't properly include the Indian healthcare delivery system. And then we've had to work to adapt it. So Catherine, sorry for making you go last, but can you, I think, Yakima's had a very different relationship, I think, than the other experiences. So could you want to share how it's worked?
Yeah. Can you guys hear me?
Yes, we can.
Okay. So actually, we have been very fortunate when the ACHs had first start reaching out. We were very fortunate. So Carol Mosier and Wes Lucky, they I don't know how they ended up, contacting me, but with that, we were able to get a meeting with our health, education, and wellness chairperson of the Tribal Council. Back then, it was Frank Metzley, and we met with him along with, I believe, Delano Saluskin and Moss, or we don't call him Moss, yeah, Moss, Raymond Martlowit, and they pretty much discussed, the purpose of the ACH and how they would like to assist us in, making all these transformations. And to be quite honest, when we start talking about all those transformations, it was intimidating. And, looking at the funding, but all the reporting, I was like, there's just no way we can do this without, having to hire, develop programs and all this, I run my own program, and to be a big part of, this whole Medicaid transformation, it was just too overwhelming. And I'm very thankful that Carol and Wes, said, well, let's just, one thing at a time. And when we started the medical transformation, the projects, we as the Yakima Nation decided to develop a behavioral health aid program. So, we started working with the Portland area office and Heritage University to implement an accredited BHA program. And Carol and Wes have, served on that because, we had to develop a committee and go forth. And they've been pretty helpful in this project. And we also been trying to develop a legal and protocol framework, cross-program patient consent mechanism, and governance model for IHS Service Unit and Yakima Nation 638 programs to work more effectively together in delivering healthcare, implement collaborative care model for physical and behavioral health, and coordinating care for other services. Because, behavioral health, we are a PL 638 program, and IHS is its own entity. And we were just trying to integrate our behavioral health into the primary care, service provider, which is IHS here on the reservation. And it's been very tedious, and there's a lot of bureaucracy involved. And again, Wes and Carol have also been gracious and came to some of those committee meetings because we had to develop a committee to start it, and gave us a lot of information on developing MOAs or MOUs, and giving us a lot of policy how this can work. And we did actually get some MOAs in place, but because of the pandemic, when the pandemic hit, that really put a lot of things on hold. And so we also are we're developing this other program. It's called the Commons Project, where, we'll be able to develop this database for many of our human services programs, like behavioral health, our SUD program, childcare, voc rehab, just for us to all to be able to come together. And because I hate to say it, but there are some people who tend to abuse a lot of systems and, milk a lot of funding. And one of our biggest purposes for that is, to salvage some of our funds and to, give it to people who really need it, and to be able to look at other case notes. It's just like this big cross-program patient mechanism. And we started that, but because of the pandemic, that has been put on hold. And we also are doing a collaborative and partner with other tribal programs to form a continuing consistent sectors such as education, behavioral health, justice, child welfare, law enforcement, to identify and review resources to strengthen local healthcare delivery. We, the Yakama Nation, have developed a small committee to head that and to bring all these programs together to actually, figure out how we're going to do that holistically. And
So,
when the
Catherine,
pandemic hit, yes.
sorry. You just made a really good point about, kind of the point I was making about sectors, is that a tribe within itself is almost an entire ACH. And that's kind of the work that Yakama Nation is doing, is really coordinating all those services across all of your programs.
Yeah, it's a lot of work. I mean, but when the pandemic hit, Carol called and she said, we have a small amount of funds to help, programs to provide services, because when the pandemic hit in March, we were all sent home. And unfortunately, when that happened, that left a lot of our patients without any care or services. So with that, we were able to, buy some equipment to provide telemental health services. So we are seeing patients again, but only by telemental health services. But
behavioral health, yes.
It's a start. Yes, but it's a start. Our people are getting, their mental health needs met, and we've been very fortunate. I really do appreciate Carol and Wes.
And you've had that great relationship all along. So maybe Tony and Andrew, you can talk about how the relationship got better. Yakama has really benefited from the leadership of Carol Moser and just their ability to work with them. Yeah. So Tony.
I would say that, to be really honest, the relationship got better because of money. What Vicki said in the beginning. I'm almost willing to do anything to serve our patients, and if it's to hold my nose at deep institutional racism, I will do that. I mean, we have done that for the last 500 years to save our children, and not to be dramatic about it, but that's pretty much what it came down to. We actually had a huge debate at my board of directors. We had staff that said, we need to cut our contract. We don't want anything to do with them. And the board is like, and half. And I was like, well, it brings us some services to our community. But I just want to say, and then they stole one of my staff members, but it was good because she actually turned out to be one of the very best things about healing in our relationship. She's a tribal member, and she became the tribal liaison. That work really facilitated healing and movement. I would say we went from total enemies to partners, maybe moving towards friends. I don't know. I think we're all going to have to be friends. But I just want to say the three things that this whole integration has done for me as an urban Indian health clinic. As people may or may not know, the funding for Indian health services is in the Affordable Care Act. It's the gas that makes us go. The Indian Healthcare Improvement Act is embedded in the Affordable Care Act. That goes away, so does our funding. So we got to figure out that. But it actually gave us some good skills or good benefits. And so the three things I had to do was to really operationalize this integration, which we, again, organically have done from IHS. I'd put metrics, like Andrew said, around what are my behavioral health and medical we're doing. Also concurrently had to work through that devastating racism, and let's just call it out for what it was. It was a health condition for us at the Data Project, because we knew we were swimming in that deeply racist environment. So we had to work through that ourselves. And then the third thing was concurrently working with an ITU system. like Vicky, so all three of the systems from IHS are represented on this panel, the I, the T, and the U. We're not used to working together either. We were kind of siloed. We kind of had learned oppression. You know, reservation Indians are better than urban Indians. You know, that's a big internal oppression that we've been colonized to believe. And so we just really, I really have to give Vicki and the American Indian Health Commission, you know, they really facilitated us moving forward together. So that tribal ACH was very helpful in terms of healing and getting us organized. But the end of it is we learned some things. We're going to see if we keep our Affordable Care Act. We're going to see where the future leads us. You know, 10 years ago, 30% of our patients were uninsured. Today, only 3% are uninsured because of the Affordable Care Act. And the other thing is we used to get 1% of the IHS budget. 1% of the IHS budget served 70% of the Indian people in this country. That was crazy, but that has gone down. That's been recalibrated a little bit. So some good things have come out, and we're friends. We're kind of friends with Better Health Together. It's working out.
This is Kathy. Can I just add that, you know, like I said, we have a great relationship with our ACH, and we had put on this conference it's our annual historical trauma conference.
Oh.
And I believe Carol may have attended a few sessions and she really liked it. So what we ended up doing for some of the ACH members is that we actually, Arlen Washings, our Human Services Deputy Director, he actually did not a conference, but a training on, you know, the history of the Yakima people and historical trauma. I mean, it was a great presentation. And I mean,
yeah,
they wanted to learn. They wanted to know us as a tribe and how our tribe operates and, you know, what our people go through.
That's wonderful,
on
Catherine.
reservation.
Yeah, and I think that has been part of the work that the commission has really tried to do is share the knowledge, because as Tony, I believe, said earlier, we're all victims of the public health system, and it really doesn't teach us what really happened to Indian people. Even in this state, there were Indian wars. People were killed. You know, they hanged the chief of the Nisqually tribe, Chief Leshai. And, you know, those things have impacts on the relationships, and we can't pretend them away. And so some of those work has been dealing with that and really helping people understand where the trauma comes from. So thank you for sharing that, Catherine. Andrew, do you want to talk a little bit about how things got? I know Elia was a big change in the OCH, but you know, how did the relationship change, and what was the work that was done that, you know, really helped the tribes and the ACH?
I think really the most important thing is once Elia came on board and tribes were included in the meetings, that we were able to sit at the table and not be on the menu. And we would help, you know, we could help write the menu and figure out the programs and figure out what the OCH was going to look like. And so that was really important to have the tribes at the table. I'll be honest, I had to do some arm twisting on the tribal side because of those same questions. Why should we be involved in the ACH? We already have a lot of meetings, and we are already stretched thin. And part of it came down to money. Part of it came to not wanting to be on the menu. And remembering that we as tribes are not fully funded and can't provide 100% of our health care on 32 or 35% of the need that we get funded at. And that work continues today. We work on increasing that so that the federal government meets their treaty obligations. And I'm veering a little bit, so I'm going to kind of come back. Right, and I see Marilyn's comment here. Yeah, Elia came and had been working in the North Sound, and that experience was absolutely integral and made the difference in the Olympic region to include tribes. She wanted to include tribes, and it flowed down through the organization. And I was able to listen to a previous panel, and Celeste is continuing that work in the Olympic communities of health in the Olympic region. And I got to start with her before I switched over to the North Sound. And I'm so happy, Celeste, that you're continuing that work and embracing the tribes and embracing that equity message, not only at the top or in one position, but throughout the organization. I mean, that's really, really going to create a vibrant ACH that is going to serve all of their residents in the best possible way. So I think what the takeaway I have is that if you want to create tribal partnerships, include them at the table, include them in the decision making, recognize that we have 29 different tribes in Washington state. We operate 29 different ways, and that including one tribe at the table is not enough, because if I'm sitting at the table for the Suquamish tribe, I can't speak for the Hoh River tribe or the Makah tribe. I can't speak for any of the other tribes other than the one that I'm sitting there representing. I can convey, where we are with things, but it's really important to have each of your tribes involved in the decision making and be at the table. I can't stress that enough. And the benefits are huge. Here at Digwalich, we provide all kinds of services under one roof, everything from a full service medication assisted treatment. We provide primary medical care, hepatitis C screening, as well as behavioral and mental health services, psychiatric and diagnosis and management. We have acupuncture. We provide transportation, as well as childcare. And we have a social worker on staff as well. So we provide that evidence-based services. And we also provide culturally appropriate care, including tribal cultural activities. And we reach out into our communities. But we do that across the region. The tribe recognized very early on that solving substance use abuse on the reservation did not stop at the reservation borders. And so we take anybody who wants to come through the door if we have room. We're full and an essential service. But 85% of our clients are non-tribal. And so we work throughout the region, and we work with our partners throughout the region. And it's really important that we have those partnerships and they're in place so that people feel comfortable referring to us. And so I think the region has done a really good job in creating those partnerships so that all of our region can benefit from the work that we do.
Thank you, Andrew. So there's a question in the chat box. MCOs, ACHs. Tony, sorry. Go ahead.
Make a comment on Andrew's comment.
Yeah.
Remember in Spokane County, people from 300 different tribes live here, and there's more in King County. So clearly, Better Health Together is not going to have 300 different representatives on their board. But I think what Andrew says is very important. You ask the tribes, but you also ask the tribal community. We're all here because of public policy. We're here from relocation. We moved to cities to help the war efforts. And that was the shipyards, that was Kaiser, that was the mines, that was the railroad. That's why we live here. We help to rebuild this country. So we're citizens. We didn't lose our citizenship though. So again, consult with the tribes and the tribal communities that you're near.
Thank you. Sorry. No, thank you. That's a really good point, Tony. And it kind of answers a little bit of the question. So MCOs, ACHs, providers, and community groups all express a willingness to partner with and support tribes and urban programs in the state. What advice do you have for how they can do a better job of that? And I'm sorry, I'm going to take a little liberty and speak first, even though it's probably not okay. Okay, as long as Tony's okay. And I think from the very beginning, when we were talking to the state about this engagement, they're like, oh, and the tribes will get so much out of it. And we're like, we think you got it backwards. lo and behold, when we held those meetings, those regional meetings, and engaged with the ACHs, they're like, "You're already doing all this stuff. Oh my gosh, can you guys help us?" And the answer is that takes money. We don't have the time. And so really, being thoughtful about the time that you take with the tribal leaders and tribal staff is really important, but also know that, deeply underfunded programs can do the best they can to help the communities, like Andrew shared with his Wallach, what the Native Project and Seattle Health Board do in those urban regions. But, don't ask tribes and urban programs to do things for free, because they're busy, and you're basically taking services away from people when you do that. So be thoughtful about your requests. Any other thoughts to the best way to work with tribes and urban programs? Tony?
I think I like all the MCOs have those tribal liaisons. That has been a very good model for working with us. And so not just have them as window dressing or a tokenism, but really empower them to facilitate conversations and help us with our contracts. That's been a challenge a little bit, because usually the tribal liaisons aren't empowered to talk about money and contracts, but why not?
Thank you, Tony. Andrew, do you have anything to add? Catherine? Do you have anything to add?
I agree with Tony. I think, yes, don't tokenize us. And, if you want us at the table, let us be at the table and be present. I've sat on other board or committees where I'm like, you are totally wasting my time, because I'm thinking about the 20 million things I can be doing at work. And I'm like, okay. But I like I said, I do really appreciate how Carol and Wes engaged with us, and, took upon themselves to want to engage in a training to learn more about our people. And, that doesn't happen a lot. So,
yeah.
Yes, I agree with Tony.
I just want to say,
Yeah, and I
was going to say the table analogy I heard the other day. It's not on the menu, but we're not going to be equitable until we own the table. So not just on the menu, but we got to own the
Andrew.
Vicki, I just want to touch on something that you brought up, which is if you have a tribal health director or you have a tribal leader at your table, just recognize that they have a really broad scope of experience that they're bringing. If you have a tribal leader, he's not only worried about health, he's worried about the budget, he's worried about environmental health, who's going to fish, is the crabbing season open. All of those things are going through his mind or her mind while they're at the table. And if they're at the table with you, they've made this a priority, and it's really important for them. And I think it's important to recognize that. And as a tribal health director, you wear so many hats. Everything's integrated, everything weaves together, and so we worry about everything. We worry about that whole person and whether or not the person has housing, whether or not they're getting the behavioral health care that they're getting, where they slept last night, where they're going to sleep tomorrow night, how their kids are doing. You get to know the whole family. You get to treat the whole family, and it's a really unique experience. And tribes are happy to share that experience with you if you let them. Thanks.
Thank you, Andrew. Catherine, you touched on this a little bit, but can Andrew, Tony talk about the impacts of COVID-19 and whether or not there was partnerships with the AC or ACH in your region to help face some of the challenges? Tony, did you mention money?
I keep mentioning this, but remember the ground zero patient in Spokane County was a patient at our clinic. She's a Native woman with children who lived in this tiny little apartment. And that was way back in March. And we have been so disproportionately impacted since then. And it wasn't a tribe from Washington State, that woman and her family. But, you know, we know right now that 3.5, we have COVID 3.5% higher than any other population in this state, 3.5% higher. And when you look at the relief funding, and we don't know, and we haven't figured out how to plan for the future either, not specifically for our communities. That's what the ACHs can help us do. And not to come in and save us and say we got resources, but really to hear. And you know, our community lives in Spokane County. They go to Safeway with you. So I mean, our ACHs are it will serve them to help all of our community together. But I think we're going to have a huge cleanup job. We're incubating trauma with our kids, even as we speak. You know, these are the conversations we need to have as communities on how we're going to move forward.
Vicki, do you want to tell the H1N1 story, and then I'll piggyback on that?
Man. So, you know, we keep talking about tribes being public health authority. Tribes are sovereign nations. They have the right to govern their own people. And among those rights is to choose your priority population for receiving vaccines. So back in 2009, during the H1N1 pandemic, you know, tribes exercised that right. And unfortunately, because of lack of knowledge on the part of LHJs and some DOH staff, some tribes did not receive their H1N1 vaccine because they weren't using the right priority. And as a result, I believe we lost some elders at a couple tribes, and we have spent the last 11 years trying to fix that problem. So is that a good enough segue, Andrew?
Thank you, Vicki. Yeah. And so that was a huge learning experience for tribes, and knowing that being at the table saves lives in your community. So we're at the table. We're for the vaccine development and the vaccine distribution planning, not only at the state level, but at the county level. But we still have work to do because decisions haven't been made on which vaccines are going out. And I think many of us are participating in that process. When, you know, there's so many questions right now: which vaccine are we going to get? Which ones are they going to be safe? How are we going to do that distribution? Are they going to be super cold or just really cold? So many questions about how we're going to do that distribution. And one of the things that we're working on is how are we going to distribute that vaccine within our communities. And we've learned, and we're going to do that education not only as we make those priorities, but we're going to share those priorities with our local public health as well as our state public health partners, so that they understand that that's the way that's important. That's why we're doing it our way. We're sovereign nations, and we need to be able to do that. And Tony mentioned that a Native American is 3.5 times more likely to get COVID. The even scarier statistic on that is if you're Native American or Alaska Native gets COVID, they're 5.5 times more likely to be in the hospital. And so that's going to have an impact, particularly here in the Northwest, because we do not have an IHS hospital to send our patients at. That's another fight. That's another whole panel. But so when our tribal members get sick, or whether it be on the reservation or in an urban area, they're going to end up in a hospital, and so that's taking up and being in one of your hospital beds. And so the work that we do for prevention, not only in Washington State, is important, but is really vitally important in the populations that we serve.
Thank you, Andrew. So with 6 minutes left, we got an equity question. So I know that's not enough time to talk about it. We did have one follow-up. Tony, would you talk more about incubating trauma? What does that mean? Yeah.
You know, when we have this integrated in-person self-care, you know, that your spirit is as important as your physical health and your mental health. You know, I think of all the kids in our programs, and we have a lot of programs, you know, Catherine knows this. They're sitting at home right now. They're not at school. They're, you know, 40% of the kids in this area have not even signed on to school. And I suspect it's a lot of our community. But I think, you know, we have incubated trauma in Native people. That's created the institutional racism for the last 500 and some years. We're creating a whole, I think, generation of kids that we're going to have to really mindfully plan for how we give them support, so we don't have, you know, Andrew's treatment center is not full to the rim in the next 20 years. We don't know how we do this. How do we support and undo trauma from telehealth, on the video, on the Zoom? You know, all my grandkids, this is how I talk to them every day. That's not what they want. They want to hug me. They want to go to some event. So we're gonna have to figure this out. And I think that, again, bow wave in 10 or 20 years is it'll be the primary medical condition of what we have done with our spirits and our minds. My prediction.
Thanks,
we see it now.
Yeah.
We see it now.
And I think addressing trauma, you know, we passed the Indian Behavioral Health Bill this last legislative session, and we defined historical trauma and resilience in state law. And those two things were really important, because prior to that, when we talked with the state about, you know, covering historical trauma or intergenerational trauma, they told us that was not a thing, which was actually a very harmful thing to say to a group of Indian leaders. But so now it's in state law and they can't say that anymore. So, you know, really the focus on trauma is important. As Tony said, and understanding that, you know, people across the board suffer trauma. This intergenerational trauma is something very different. And it's something that is really impacted the health of Indian people in Washington State, the health of Indian people. I think it was it 2014, the study that showed that a non-Hispanic or an Indian people die at 71% higher than non-Hispanic white people in Washington State. 71%. That's not, I didn't stutter, that's not 17, it's 71. So that is, and trauma plays a great role in that, a huge role. Do you have anything to add, Andrew? And then Catherine, we got 2 more minutes, sorry.
I'll just say, you know, I think even as a service provider, we have to know and understand the you know, trauma, intergenerational trauma, historical trauma itself. I got to read an article from Maria Yellowhorse Braveheart, and it was her Indian Holocaust article that she wrote a couple decades ago. Anyways, what I had brought, you know, what I've learned from that, Mighty Camp Servers are, you know, a program director. I don't care, you know, native, non-native. I make everybody read it, and then we come to the table and we discuss it. My biggest question is, how does this article pertain to our work and to the people that you serve? And an open discussion, and our non-natives actually appreciate it and they learn a lot. So that's pretty much where our conference had been stemmed. And our first annual conference, we actually got Maria down as our keynote speaker.
Oh my gosh, that's great. Hey, Catherine, there have been some requests about the training and the article, but maybe when you do the conference again, do you think it's okay to, I know it's kind of weird to invite non-native people.
No, actually, we love non-native people.
Okay, is it, maybe we can send that to the ACHs and.
Absolutely.
Okay, yeah. Andrew?
Knowledge is power.
Thank you, Catherine. That's, I would have loved to have gone to see Maria Yellowhorse. Andrew, any final comments?
I would just encourage everyone that invite tribes to sit at the table if they aren't already there. We are the innovators we are happy to share our innovations. The Digwall-Eats treatment model for opioid use disorder, we share openly. It's on our website. We have a paper coming out. There was a link shared to our story, which is up on YouTube. Take a look at it. We are working on sharing that model widely, happy to help your community in any way that we can. We recognize that opioid use does not stop at the border of our reservations, that we need to treat our whole community. And I would hope that we could work with you and your communities to do that. There are other ways that tribes are innovating, including creating mid-levels for dental health aid therapists, behavioral health aid therapists, community health aid therapists. That's something that the Northwest is leading, and that there are many ways that tribes bring their experience to the table and share in ways that you wouldn't expect, and it's always a learning experience. Thank you.
Thank you. And Tony, I'm going to give you the last word, not because you're old, but because you're my elder, and I respect you and your knowledge and experience, and you're one of my very favorite and best role models. So
well, thank you. That was the look I was going for all these years.
Okay.
I would just say that to be willing, I think, to undo racism and undo structural racism is just like Andrew said, it's like giving up opioids. You know, it's so embedded in us, and the process is the same. And that we get to a point where there's no crying at the ACH. There's no crying in undoing this work. It's just willingness. It's willingness. And I really appreciate Allison Polson for inviting me. How shocking is that she would invite me to be on this panel, given the horrible, contentious relationship that we started out with. And we're at this place now where we can have a conversation and to, as we move forward, we have to do this together. I mean, it's no more. It's no more. That is what the events of this year has shown us. And I think there's a lot of missed opportunities. Every ACH in this state has missed opportunities to learn from the great tribal partners that they could have had. And we will raise all boats, we will raise all teepees, whatever we want, longhouses in this state, that we really get to that place where it's equitable and our children and grandchildren will have care that's integrated and effective. And it doesn't cost us so much. So thank you again. And, I love being with Andrew and Vicki and my new friend, Catherine. And thank you guys. Thank you very much. And Marilyn. Hi, Marilyn.
Yes, hi, Marilyn.
Marilyn tells us all what to do. Hi, Marilyn.
Well, and thank you all who joined this panel, and we appreciate your willing to hear our stories, and hopefully we will be seeing you at the table working together in the near future. So I'm going to pass it on back to Bonnie. I don't know if we have to do anything on the screen, Bonnie, or if you just take it back over from us.
Nope, you should be just
when
fine.
we own the table.
When we own the table. Yeah, we'll invite you to the table when we own it. How's that? Let's end on that.
That's great. Thank you so much. And thank you. And thank you everyone for joining us today. We so appreciated your presence and engagement in all of these panels. Just a couple of reflections before I close it out. I just want to start with our first session this morning. We received really great feedback on our health equity journey that we're just beginning. So many good questions and feedback were provided through the Q&A, and we're honored to be able to take that back as we continue this journey. So thank you everybody for your participation in that. I also really like the frame of individual, organizational, and systems levels as a way of thinking about the different levels as we address equity. That really stood out to me, as well as it's not on the plate, it is the plate. So that was another one that I'll be remembering. I also want to say thank you to our social determinants of health panel. There's just some really amazing work going on in that space. And I also want to say thank you to AJ for sharing the story of what happened to your family this week. You highlighted a real-time example of why we need to transform these systems of institutional racism. So thank you for sharing your story. I also this panel that we just heard on tribal partnerships That was just incredible. The work has come such a long way. There were so many learnings for me, and I'm sure so many more of all of you in that panel, and hearing the stories from Tony and Andrew and Catherine and Vicki about working with ACHs, both in the beginning and now, as well as a really important reminder that tribes represent multiple sectors, many, many sectors. That was just really important to hear. So just want to give a huge, huge thank you to everyone who participated in panels today and who showed up as attendees and submitted questions and feedback to everybody. Thank you so much for being here. As a reminder, all of the recorded sessions and slideshows will be available on the Washington ACH website after tomorrow's session. So that's www.washingtonach.org. We hope to see you again tomorrow, starting at 8:30. We've got 2 sessions and then our closing keynote tomorrow. We'll start with bridging the gap between clinical and community providers. Then we'll move to a panel on the future of accountable communities of health. And then we have a much anticipated closing keynote from Nicole Maher, who's the CEO of the Group Health Foundation. So we hope to see you tomorrow at 8:30 and we'll do day 3. So thanks again for being with us and we hope you have a wonderful afternoon. Take care.
Thank you.